Okay, now we get to see if I really can lower this podium. Look at that. Okay, well, we're going to discuss genetics as the ultimate host factor, I suppose. I would like to thank the organizers for the privilege of attending this last St. Gallen meeting. And to thank you so much. In the dog theme, I would only say that I wonder if there's a different genetics between dog people and cat people that might affect some of what we'll study. Okay. So my disclosures, I have been doing some work with PARP inhibitors still. So genetic testing and outcomes and treatment have really changed over the years of the St. Gallen meetings. From the beginning, when I think this was included because it had to be, to a time when we think now much more actively about knowing the genetic status of our patients to help them make treatment decisions, and of course to recognize that the information that goes back to the family is important for prevention. But this is not a prevention talk. Still, the issue of when to test your patients, whom to recognize in clinic when you have largely a breast cancer population remains important. And I think this list still covers most of it. Obviously, patients much more now come with a known genetic mutation in the family, sometimes just age, as we heard yesterday from Will Folks, people with ovarian history and history of what could be ovarian cancer or related tumors. The pancreatic tumors are part of BRCA2 in particular, but also BRCA1 and other genes, as I'll mention. And then the pathologic features that Dr. Folks so clearly discussed yesterday. So this is a different way of looking at this issue of the distribution of ER and PR status by BRCA1 and 2 status. And this is the triple negative view of the world because you have to subtract out more or less. These are pathologic subtypes looked at by ER/PR negative, HER2 negative, and triple negative. And these are data from the SIMBA consortium with 4,500 BRCA1 carriers and 2,300 BRCA2 carriers, so quite large, and showing, as we heard, that the BRCA1 tumors, 70% will be ER/PR HER2 negative or triple negative. That doesn't mean they're all basal-like, as we also heard yesterday. And in BRCA2, the predominant phenotype is ER/PR positive HER2 negative. But as you can see, all of the subtypes are there. They're all represented. 10% are ER positive. So you cannot use subtype to exclude testing for BRCA1 or 2. Really, phenotype can only increase your interest in testing. And the guidelines now in the NCCN and others have suggested testing at least of triple-negative breast cancer patients. Will showed yesterday 20% prevalence of mutations in women under 50 and 10% overall, and that would make all criteria for testing. The interesting thing this year, these are our data, but 2 other groups also reported before us really on the prevalence of HER2 positive breast cancer in P53 mutation carriers. 2/3 of them have ER positive tumors, 2/3 have HER2 positive tumors, and there certainly is overlap. Why that should be true when BRCA1 related tumors, triple negative breast cancer, so often have a P53 mutation? Is this a cell of origin issue? Is this a sequence of mutation issue? I don't think we really have the remotest idea at this time. Now, we've seen variants of these slides. What do we do when we recognize someone who looks like a member of a family with a predisposition or unusually young patients, and we wonder where else should we be thinking about looking for genes now? And of course, all of the technologies that you saw yesterday from Matt Ellis and Chuck Peru looking at multiple genes concurrently. Next generation technologies can be done on the germline as well as the tumor, and certainly they are. Here, though, is thinking more functionally, looking at the DNA repair pathways, and this is a slide from Elizabeth Swisher and Mary Claire King's group, just reminding us of the pathway interactions between homologous recombination repair, the Fanconi anemia genes, finding a group. All the red, green, and blue on this slide are genes that are important in breast cancer susceptibility and ovarian cancer susceptibility. So the group in Seattle there looked at 360 consecutive unselected women with ovarian cancer and looked at their germline genetics for 12 of these DNA repair genes. And as you can see, in ovarian cancer, 24% had a mutation, of which 2/3 were BRCA1 and 2, but then there were a smattering of these other genes that are all involved in DNA repair. This has led in the US to the development of panels of genes. So instead of testing only for BRCA1 and 2, which is done, as you may recall, in the US by a single company that still has the patent on these genes, in Europe, where each country has developed their own individual testing, this has worked quite differently. But in the US, for the same cost of looking at BRCA1 and 2, you can now look at panels of genes. And this wasn't here so you could pick out the genes, but they're all DNA repair genes at this time, and they're being added based on various criteria to the different genes. So at least there's competition here, but the costs are the same. The testing is largely being covered by insurance for individuals with cancer, so not their unaffected survivors or family members, but cancer patients. Even in the US, Medicare, until they figure this out, is covering this testing. So for women who look like they should have a mutation and don't have a BRCA1 or 2 mutation identifiable, it's at least possible now to look at other candidates. Of course, we know far less about these genes. There's very little epidemiology left. There's really more case report kind of information. So we are not yet able to give very good estimates of the cancer risks associated with these tumors. But this is where we were 20 years ago with BRCA1 and 2. Now we're much better organized, and the data to give our patients better information will be forthcoming much more rapidly. One of the problems of this kind of analysis, however, is the increasing identification of variants. So mutations in the genes or alterations in the sequence that are not so clearly functionally significant, but missense mutations, which sometimes turn out to be functionally significant. And there is a lot of analysis that must go on to try to figure this out. Certainly some of this can be done computationally, and much is, but there are other criteria. And just so you know, the group formed called Enigma, which is an interesting acronym after quite a bit of debate, but perfect for this, trying to understand the significance of these variants that we're going to be giving patients. Now, these are, Enigma is really a group of largely European investigators, but with contributions from the rest of the world, to try to classify these variants that are identified in BRCA1 and 2. But the plague of looking at less defined genes or genes that have been looked at in so many fewer people is that in the beginning there will be many more variants that we won't be able to explain to patients until data accumulates. And that is the truth, but at least there is a precedent for how to approach this issue. And this is a problem more and more as we go to large-scale genomic analysis, not only of tumors, but certainly of the germline as well. So if you take a more genomic view of cancer, and we've heard of the tremendous power of this approach in looking at somatic genetics, the genetics of the tumors, you realize that at the same time that all of these analyses, or many, are being done on tumors, there is, of course, concurrent analysis of the germline, because you want to be able to subtract out the germline data and be left with the acquired mutations in the tumors, the one that might be driving the malignancy so that they can be targeted for treatment. But all that germline data is still there. And we are going to need to think as well about capitalizing on the fact that we've paid for it and it's being generated, and we should be looking at susceptibility genes in these analyses, or we will be missing an opportunity to see what could be very powerful host interactions. And this is certainly being done. Here's the TCGA, the large genomic analysis of 500 breast cancers published earlier this year. And within those 507 unselected tumors, although they did have to have a size criteria to have enough tissue to be in the project, you can see that 10% had identifiable germline mutations in this very similar list of DNA repair genes. And I thank Ken Offit for this slide. So you know that it's there, it's just not been the focus of the analysis. So we should not forget to look for this. It's the freebie on the side. And why are we looking? Well, obviously tumor targets from the tumor genome, but in the personal genome, in the host genome, besides the susceptibility genes, which their interpretation for family members, are pharmacogenetics, which hopefully will get a big push from the availability of this kind of data, and also, of course, the incidental findings of mutations in genes that we may not have been interested in. We tend to be a pretty cancer-focused group. But you know that once you start looking, you're going to find those mutations that we all carry in other genes that may or may not have direct therapeutic implications or risk implications for our own patients, depending on whether we're looking when they have advanced metastatic disease, looking for treatment, investigational treatment perhaps, or whether we're looking earlier and earlier in their care. These other incidental findings we have to think about in advance in preparation for how we're going to deal with them for our patients and their families. So this is just a small advertisement, I suppose, for a project ongoing at Dana-Farber looking at the implementation of this kind of whole genome approach in the clinic. And these sorts of projects, sequencing tumors and germline in patients for treatment effect, are going on at many institutions at this time. But we may be stuck there. Now, why else do we want to know? Well, certainly we assume and we hope that in our treating our breast cancer patients at diagnosis that we're going to see good outcomes. And many of them will want to survive, of course, many of them do survive, and then we'd like to go on to worry about their second cancer risk. These are the data from a non-cancer population with BRCA1 and 2 mutations, showing that there is a mortality reduction with oophorectomy. So for our patients with their triple-negative disease, we don't really expect oophorectomy to affect their tumor prognosis, but if they're survivors, we expect perhaps to avoid second cancers as ovarian or breast cancer, and oophorectomy conferred the survival advantage here, not mastectomy, although, of course, many patients use their BRCA1 or 2 status to make surgical decisions about bilateral mastectomy versus more breast-conserving approaches. Even in P53, there are intriguing data to suggest that Li-Fraumeni patients may benefit from a screening approach that acknowledges their risk for many different cancers. These are very preliminary data from the Toronto group that have led to many small studies evaluating whole-body MRI. But these patients, too, in the era of HER2 therapies, may do better from their breast cancers, so then we have to worry about their additional primary tumor risk. So let's move on for the rest of the talk to talk about therapeutic issues related to recognition of BRCA1 and 2 status, largely at diagnosis. So these are the Israeli data, which I think are really so helpful. These were the data looking at patients identified 20 years ago who were typed by ER-PR status, and then in Israel looking at founder mutations, and finding that as long as BRCA1 carriers received adjuvant chemotherapy, their outcomes were similar to BRCA2 carriers and to non-carriers, the much larger group. And of course, these were patients treated long enough ago that their primary treatment was CMF. So here was CMF data showing some effect. These very important data came from MD Anderson this year, looking at the neoadjuvant experience at MD Anderson, which of course is quite large. And Banu Arun's group showed that BRCA1 and 2 status, BRCA1 status, I think, in this study, actually conferred an advantage in achievement of pathologic complete response in their TFAC group. So this suggests that perhaps mutation carriers are more sensitive to standard adjuvant chemotherapy, something to keep in mind. Now, we did this tiny study of platinum in the treatment of triple-negative breast cancer, and this was done based on the question of whether the behavior of BRCA1 in particular, but BRCA2 as well, as DNA repair genes concerned with repair primarily, though certainly not exclusively, of homologous recombination defects or double-strand breaks in the DNA, the very thing that platinum causes, could cause, whether that could give these therapeutic advantage, at least to a subset of triple-negative breast cancers. And in this tiny study, the BRCA1 carriers had pathologic complete responses. Now, I should point out that in the subsequent study, of course, this was not uniform. And I apologize, I cannot find my slides of the data from the Polish group who took this platinum regimen into individuals with BRCA1 mutations found by screening for the founder mutations in that population and showed an increased rate of pathologic complete response. They haven't published their final data yet. We'd all like to know what the final response rate was. So platinum's being evaluated now in triple-negative breast cancer in this study from the CALGB, which I understand will have results probably at the end of this calendar year, and teach us something perhaps about the value of platinum beyond mutation carriers. And in a multi-center study in the US, we're asking the question of whether adjuvant platinum really offers an advantage over adjuvant AC standard chemotherapy in BRCA1 and 2 mutation carriers with either triple-negative disease or high-grade ER-positive disease in the BRCA2 carriers. So perhaps we'll have an answer, at least from a simple study like this. Oops. But we may be stuck here. There we go. So PARP inhibitors. So we've seen great interest in PARP inhibitors, great disappointment in PARP inhibitors. Where are they in breast cancer? And I think that whatever happens with triple-negative breast cancers or other breast cancer and PARP inhibitors, not in mutation carriers, there are many of us who believe firmly from the data that there's quite a bit of reason to be optimistic about these drugs in our mutation carriers. And these are from the original iceberg studies, the first trials in which BRCA1 or 2 mutation status was an eligibility for enrollment, which is no longer the case, just the first, showing a significant response rate in BRCA1 and 2 carriers to the first of these PARP inhibitors. And the data expressed another way showing even in these heavily pretreated patients, about a 43% response rate with an oral agent that, compared to most chemotherapies, remains well tolerated. So we've been through the plus and minus years of interest in these drugs. They have made some resurgence. You can see that even the drugs that were originally or at some point owned by larger pharma have gone back to smaller pharma, but there is interest again in developing trials for mutation carriers, so stay tuned because they are coming very much to theaters near you. The mechanism of PARP inhibition has received more attention. This was the idea of the synthetic lethality, that having a drug that targeted not the specific mutation, but the pathway for which sensitivity was conferred by mutation, is clearly part of the basis of this thinking. But there has been new data suggesting that PARP inhibitors actually are active at many sites in the DNA repair pathways. So remember, we have 5 well-characterized pathways, and we have many different areas where these drugs appear to have function, not only by regulating the PAR enzyme itself. And I show this next slide as part of this very nice work from the National Cancer Institute that showed that even comparing across PARP inhibitors, that there's a difference according to many of the DNA repair genes down the sides, not only the genes involved in homologous recombination or in nucleotide excision repair, which was the basis for much of this work in the beginning. And the question, I think, will still be with these drugs, is it only BRCA1 and 2? Are we going to be able to generalize to our other mutation carriers, those we're finding as we go down the pathway of DNA repair genes? But these data from Nellie Polyak at Dana-Farber ask the question of what is the first event in BRCA1 or in this case BRCA1 tumors? Is it loss of the second allele of BRCA1? And I don't know if I'm going to really regret this, but here you go, that's it. This is the showing that P10 loss was actually the first event in most of the in the BRCA1-related tumors, followed by loss of the second copy of BRCA1 and then other loss. So it may be that this P10 discussion that we had yesterday, linking us to pathways like, yesterday I thought we at least had to have one slide showing a connection to PI3 kinase inhibitor pathways, but that is true, and the data that was suggested yesterday just shows you, it depends which part of the world you are focusing on, that over here we have DNA repair, but we're still in the AKT, et cetera, segment of the world, and that there are data to suggest that the combination of PI3 kinase inhibitors and PARP inhibitors could be particularly effective in many patients, but also in mutation carriers. And down here is the area where the mouse data from Gerber-Wolf's group over at Beth Israel in Boston showed that the combination was particularly effective in these mice who are BRCA1 negative, P53 altered. These are targeted therapies. There are multiple mechanisms of resistance. One of them is the acquisition or the overgrowth of the subpopulation of cells that have reverted their germline mutation in BRCA1 or 2. In this case, these are examples from the platinum data in ovary. This has been shown in PARP inhibitors in breast cancers. This is not an uncommon mechanism in the data from Seattle. About a third of these individuals' tumors will revert or have an overgrown reversion mutation, but 2/3 do not and will have other mechanisms of resistance, and those too are being worked out, perhaps so that we can be smart enough to avoid them or correct for them in the future. This is just trying to predict, as we all do, as we heard yesterday too from Dan Hayes, assays that might predict which patients' tumors might be sensitive to platinum, if it's obviously not so simple as calling them basal-like by any criteria or triple negative by any other criteria. This is our attempt at this, and this is an assay that's being looked at trying to measure the effect of having a particular kind of DNA repair defect in the tumor cells that might make them more sensitive to drugs targeting these pathways. So we still have to help our patients decide when do they want to know, what do they want to know, and what are we going to do with the information for them when we find it. But I certainly think that as oncologists, recognizing that tumor subtype has an influence, that young patients are most likely to be carriers, can very much affect our thinking these days, and hopefully in the future we'll have data to support the possibility of targeting our therapies in a different mode than the way we do today. Today, standard of care is standard of care, even in mutation carriers, but the possibility of more treatment, particularly for those with metastatic disease, is now much greater. Thank you.